Hi, this is Dibya Prakash from Nuclear Medicine Solutions.in, and today we are going to discuss about dosimetry in nuclear medicine. We are going to see the rationale, the radiopharmaceutical and CT dosimetry. This presentation will have three parts, and in all these three parts we will be discussing about the importance, the radiopharmaceutical and the CT dosimetry. In the first part, we are going to discuss about the importance of dosimetry as it is not done in a common clinical practice. So we will learn why it should be done in a common clinical practice. And in the second and third parts, we will be saying about the radiopharmaceutical and CT dosimetry. So let's begin. These two parts are required to be learned because in nuclear medicine we are using CT as well as radiopharmaceutical both, and both of them require a different type of expertise, and they have different terms. Their method of doing is different, so we will have to learn both of them being in a nuclear medicine professionals. So let's begin. We have 6 sections in this presentation, and that includes the dosimetry in current clinical practices, the scientific statements from the scientific community, typical arguments for not doing dosimetry, and we will also discuss on the recommendations of the governing body, EANM guidelines and SOPs for nuclear medicine dosimetry, and we will also discuss about informed decision making process, about procedures that involves radiation. Means how much information should we give to the patient, should we give to this information to the patient or not. We'll have discussion on this. So let's begin. In the common current clinical practice in nuclear medicine, what happens, the approach called one dose fits all or the empirical dose approach is used generally, where the doses are decided based on the number of lesions or the extent of disease, and there is no customization of doses based on patient to patient variations, though it follows for the diagnostic nuclear medicine where doses are modified based on the patient body weight, but in general on therapeutic nuclear medicine the doses are not decided based on patient to patient variations, and this can have a poor quality sometime if it is not properly designed. And if we continue to do like this, where we are not individualizing the therapy doses, then probably we can never better our therapies. There are a number of scientific studies which says that patient individualized therapy planning is more efficient than the empirical methods of radionuclide therapies, and let's have some look on some of them. This study says like this. There is another study. This studies has searched for around 92 for the term dosimetry, and they found 92 papers, and out of that 79 studies are investigating about dosimetry, and they found an absorbed dose effect correlation was found in 48 studies, and they conclude that the dosimetry based personalized treatments would improve outcome and increase survivals. This study also says that clinical dosimetry in PRRT is feasible and can result in improved treatment outcomes. Dr. Michael J. Stabin, who has been a pioneer in dosimetry, and he has designed so many phantoms, he wrote so many papers and the books on nuclear medicine dosimetry, and he says that the only people on the earth for whom radiation doses is not calculated is nuclear medicine patients. As per regulatory authority norms, the radiation doses are calculated for the radiation workers, CT scan patients, radiotherapy and brachytherapy patients, and even for the airline pilots and flight attendants, but not for the, but there is no calculation or there is no estimation, there is no audit for the radiation doses to the nuclear medicine patients. Sometimes these patients can be children also, but there is no accounting of how much radiation dose is being given to whom. And there are typical arguments for not doing dosimetry. People have different arguments that they say that performing such calculations are difficult and expensive and require too much of efforts. They also say no standardized methods exist for performing individual dose calculations, and methods vary significantly among different institutions. They also say dose calculations made to date have had poor success in predicting tissue response. These all the questions and the arguments were compiled by these great people, and they answered and they said why this is wrong. These kind of statements are wrong when we talk about the patient individualized dosimetry. This is again given in Dr. Michael J. Stabin book, and which was published in 2017. And this argument one, which says that performing such calculations are difficult and expensive and require too much of efforts, and they say that the patient already undergoes for different type of procedures, which includes the surgeries and the chemotherapies, multiple line of therapies. If that patient can go for all those things, why it is difficult for them to lie on an imaging table for just going for 3 to 5 scans? So it cannot be called as a difficult. And regarding the cost, if they say that in a routine IMRT procedure, the cost of therapy planning is around 5,500 pounds per patient, but in nuclear medicine it may not be so much of high. But if that patient can afford there, why it cannot be used here where they get the benefit? In the argument 2, they say that no standardized methods exist for performing individual dose calculation, and methods vary significantly among different institutions. They say that the 2 MIRD publications, that includes public pamphlet 16 and 23, they provide clear methods to obtain tissue and tumor uptake from anterior posterior planar imaging, and the number of and spacing of time points is also clearly defined. They also say the software like Olinda is well established, and they have different reference models for children, adults, pregnant women, and have been widely employed in international nuclear medicine community. Means there is some standardization already done. So why there is a lack if we have facilities? These dose calculations are used in drug approval processes and for university ethics committee approvals for the research proposals. If it can be used there, why it cannot be in a current clinical practice? In argument 3, where the people say dose calculations made to date have poor success in predicting tissue response, in this response they say that though many studies failed to find firm correlation between tumor dose and observed response, but several studies have found a convincing relationship and showed that tumor radiation dose were clearly linked with the likelihood of subjects to obtain a complete response to therapy. Means they say that it is a clear link between the tumor radiation dose and the response to therapy. The European Union directives, the Euratom of 5 December 2013, they say clearly that for all medical exposures of patients for radiotherapeutic purposes, exposure of target volume shall be individually planned and their delivery appropriately verified, taking into account that doses to non-target volumes and tissues shall be as low as reasonably achievable and consistent with the intended radiotherapeutic purposes of the exposure. And they say clearly that radiotherapeutic means pertaining to radiotherapy, including nuclear medicine and therapeutic purposes. Nuclear medicine for therapeutic purposes means nuclear medicine has got no excuse for not doing dosimetry, and they say nuclear medicine treatments cannot be considered different from EBRT, external beam radiation therapy, and should be planned and verified individually through dosimetry of target and non-target volumes, and should be optimized and delivered with reasonably low doses, but not so low where the tumor does not die. Now, this is discussion on the informed decision making about radiation doses during radiological or nuclear medicine procedures. Generally, in nuclear medicine procedures, what we take consent from the patient, that and the statements are given in the consent form where the patient is saying that I give consent to intravenous injection, oral administration of radiopharmaceutical for nuclear medicine studies and understand that radiation exposure is in acceptable range. But should we not inform what is that radiation dose is being given to the patient? See, the dose limit of radiation safety protocol is not applicable to the patient. Only justification and optimization is accounted when we are doing the patient studies. And of course, dose limit cannot be imposed, as it can affect the therapy or the treatment planning. But at least an audit should not be there. How much radiation dose was given in this procedure? Was it correct or not? So should this audit be done or not? And at least an assessment should be there or not. In United States in 2017, the NCRP, they did assessment of medical exposures, which was quoted by this 2003 paper of Mahesh et al. And at least similar things should be done in all other countries and all other places also, where assessment is done and at least an audit is done. And should this clinical report, when a patient comes for the diagnostic or therapeutic purposes and they are given a report where the clinician writes that these all the findings are there, should that report not be supplemented with the dose report, which may include this kind of information like dose report for this procedure, where the patient name, patient ID, date of the study is mentioned there, dose from the CD component, dose from the PET component, and the total whole body dose which patient would have got. At least an approximation of those calculations can be given to the patient or not. At least it can be a measure of quality, where we can say that only this much of radiation dose we are giving, and we are giving a good clinical results. Or center to center basis, or the institution to institution basis, the quality measures can be, transparency can be there, that with this much of radiation dose is being given by the patient. At least accountability should be there or not. But at the same time, we should not create a fear among the patients, because once the patient will have, it may have some effect in the patient's mind that this much of radiation dose we have already received, should we go for the further PET-CT or not? Because patient used to go around 6 to 8, 10 rounds of PET-CT in their lifetime. So it can have a resistance for the referring physician who are asking for the PET-CT to the patient, and patient will say like, I have already received this much of dose, so should I go for the scan or not? So considering all, at least we should have a thought that should this be given to the patient or not. Now there are certain compulsory conditions where dosimetry is required to be done. There is no escape. See, if there is a patient, we are treating to the patient, at least we have an option that we can go for the empirical approach and we can design the doses. But there are certain conditions where we are supposed to do the dosimetry and there is no escape. The conditions which can arise, like the TLD overexposure of radiation workers. Like suppose a radiation worker who was having some cough and cold or some pain in abdomen, and they might have he or she might have gone for some diagnostic procedures, and mistakenly he was wearing the TLD, and TLD was exposed for the diagnostic doses, but it was unknowingly, and when it goes for the reading and the regulatory body sees that it was an overexposure, in those situations we are required to do the dosimetry, that this much of dose was given and it was a diagnostic dose, and it should not be considered for the doses which arises from the being as a radiation worker. So in those all the conditions, in this situation we are supposed to do the dosimetry. Next condition where it can be a medical event, or it can be a misadministration which can be done for patient, like suppose a pregnant woman was injected with the radiopharmaceutical for which the LMP condition was not at certain before the administering radiopharmaceutical, and suppose this patient gone after therapy and later on realized that this mistake was being done by the hospital or the diagnostic facility, and they file a case against you, suppose. So in those conditions, now you are supposed to do the dosimetry. So now there is no escape. And if you are supposed to do the dosimetry, then how to do the dosimetry? So let's discuss some of the misadministration conditions where we can be in a trouble. The term misadministration was changed two medical events by the US NRC in 2002, and as per this new definition, they say that a dose that differs from prescribed dose for the diagnostic, it is more than 50%, and for the therapeutic it is more than 20%, or a dose that would have resulted from the prescribed doses by more than 50 millisievert as effective dose equivalent, and 500 millisievert to an organ or tissue, or 500 millisievert to shallow dose equivalent to the skin from any of the following. For example, administration of wrong radiopharmaceuticals, wrong route, wrong patient, wrong doses. And the code further says that the radiopharmaceutical dose administration to the patient for whom it was not intended to receive the doses. For example, the patient might have been injected, and or a fetus in a pregnant woman who is administered without confirming the pregnancy, or such other cases that would be a medical event. So now we need to have an expertise on dosimetry, and the dosimetry for radiopharmaceutical and the dosimetry for CT. So thanks, and in the next section of this presentation we'll be learning about the radiopharmaceutical dosimetry. See you.